Good afternoon, everybody. Thank you for the kind introduction, and it is indeed my honor and pleasure to be back here where I finished. And if I can share some of my knowledge and some of my experience with you and enlighten this audience with the growing problem of diabetes and obesity. So the term diabesity was coined between the close relation diabetes has with obesity. And we're going to find out if this can be treated only with medicine and efforts, or is there a scalpel involved in this. So I'll begin with the story of man. God populated the earth with broccoli, cauliflower, spinach, green, yellow vegetables, and all kind of healthy diet, so that man and women could live long and healthy lives. But Satan created McDonald's and bought forth with ₹30 double cheeseburger, the value meal. Man said, supersize that and gain pounds. God created healthy yogurt, but Satan created chocolate. God said, try my crispy fresh salad. Satan said, enjoy my Ben and Jerry's. God said, I have sent you heart-healthy vegetables and olive oil to cook with. Satan said, order a pizza, you don't have to cook, be jello. Man gained pounds and his cholesterol went through the roof. God bought forth running shoes, but Satan bought forth cable TV with remote control. So man wouldn't have to get up to change channels. Man repented and resolved to lose all those extra pounds, but Satan began to sponsor Monday night IPL to extend man's weekend celebration. God bought forth potato, a vegetable low in fat and brimming with nutrition, but Satan peeled off the skin, sliced the starchy center into chips and deep fried them. Man clenched his remote control, ate the potato chips and was drowning in his own cholesterol. Man's waist grew more than his age and went into cardiac arrest. God sighed and created bariatric surgeons to perform sleeve and gastric bypasses. So here I am, standing with you. So we know obesity is a problem. How do we measure it? So there are three parameters we can use to measure. One is the BMI, the body mass index. One is the waist size. I wish we could have belts like these, so everybody can just see when you're putting on weight and losing weight. So a waist of more than 90 centimeters in men and more than 80 centimeters in women, irrespective of the height, is a danger sign. The third parameter is the body fat percentage, which we use body composition analysis machines to measure. But Asians are known to have higher body fat percentage compared to the Caucasians. And two individuals from different races with the same BMI, Asians will have a higher body fat percentage. Asians therefore are called genetically thin fat people. So how do we classify? So 18 to 23 is normal, 23 to 27 is overweight, anything more than 27 is obese. We have a cutoff line at about 32 where morbid obesity sets in, and above 40, of course, it's morbid obesity, above 50 super obesity, above 60 super obesity. What causes obesity? It's a very simple calculation. It's the amount of calories you intake compared to the calories you burn. Maybe because of your slow BMR, maybe because of your body composition, maybe because of some endocrine functions, it's a multifactorial problem. I usually show this slide to my patients and give them a brief. How easy, any one item on the left, if you consume, you can get 300 calories. But to spend those 300 calories, you need to really work hard. So maybe, and 2 scoops of ice cream, maybe just a paratha, or maybe 1.5 peg of your vodka can give you 300 calories. But to burn those 300 calories, you need to do 45 minutes of cycling, or 40 minutes of swimming, or 30 minutes of jogging. Most of us cannot jog for 30 minutes, correct? But it takes only 3 minutes to consume 300 calories. So where does the surgery criteria kick in? So we have a surgical guideline which says that we can operate patients above 32 BMI with morbidities and 37 without morbidities. This is the analysis that we do on the body composition. So what we are really targeting is the visceral fat and not the skeletal fat. Visceral fat is the one which is responsible for causing diabetes, cholesterol, and other things. Obesity is a growing problem in the industrial world. It is estimated that 20% of the population is overweight. A lot of children these days are getting obese. WHO has conducted and concluded a study where they said that obesity is the #1 health problem in the world and growing at an alarming pace. The statistics say that 1.9 billion adults above the age of 18 who are overweight, and out of these 600 million are obese. Worldwide prevalence of obesity has nearly doubled in 25 years from 1980 to 2014. A lot of children, 41 million children under the age of 5 are now obese, and out of this, half of them are from Asia. So we have a problem and we need to address it. There's another killer lifestyle that is preventable. So we have treatments which can definitely treat obesity. You need to pay attention. Obesity comes with a whole gamut of diseases: diabetes, hypertension, hyperlipidemia, cardiac diseases, sleep apnea, which is very common in these patients, arthritis. Most of them are depressed individuals. They are struggling with their weight. So interesting slide which says that almost 40% of the fat is consumed by 5% of the elite population. And to lose half a kilo of weight, we need to eat 500 calories less per week. That is 7,000 calories. If you deduct from your diet, you are likely to lose 1 kilo. So what are the options? This is not going to work, right? What is going to work? So of course, you start with diet. Patients who are trying to lose weight need to control their calorie intake. On an average, 1,000 to 1,200 calories for women and about 14 to 1,600 calories for men, comprising more of proteins, less of carbs, a balanced diet, almost zero fat intake. Protein is a very, very important source in our nutrition, in our diet, which most of us ignore. Indians especially are scared of protein for some reason. The proteins have to be incorporated into your diet. Every body needs at least 60 to 80 grams of protein a day. Vegetarians have a challenge consuming that. Physical activity. Some sort of physical activity has to be incorporated in your daily lifestyle. I don't know what happened. Okay. It has to be incorporated in your daily lifestyle. It could be cardio, it could be weight training, it could be aerobics, yoga, anything. But it has to be incorporated. I tell my patients that exercise is like brushing your teeth. You do it every day, it's a religion. There's no two ways about it. A short video which tells you that if you incorporate fun into your exercise, it becomes a pleasure. So one of the subways, what they did is try to transform it. Encourage your patients to get into exercise regime. It is always healthy, whether you are old, young, fat or thin, everybody needs to exercise. There are various different things you can follow. Of course, running at 10 miles per hour, you burn 1,000 calories. Staircase climbing, most of us live in towers, our offices on 6th floor, 8th floor, hospitals have staircase. Encourage people to take the staircase, it's a healthy habit. If exercise and diet doesn't fit in, there are some over-the-counter drugs like sibutramine or rimonabant, but they have been taken off the shelf for their side effects. The only thing available now is orlistat. So these drugs have a limited role to play, works only as long as you take them. The result could be 5 or 10% weight loss as long as the patient is on the tablets, cannot be taken lifelong. So all in all, morbidly obese patients in 5 years, whether they're trying with diet, exercise, conventional therapy, behavior modification, anti-obesity drugs, the failure rate is almost 95 to 98%. That is very alarming. What has stood the test of time is bariatric surgery, where almost 80% of the patients have maintained their weight even after 17, 18 years of follow-up that we have with them. So that brings us the question back to us, that what can we offer these patients? Bariatric surgery has withstood the test of time. This is how we classify bariatric surgery into restrictive, malabsorptive, hybrid of restrictive and malabsorptive like ROY, BJB, MGB, or pure metabolic, which deals with uncontrolled diabetics like the ileal transposition. So bariatric surgery, the history goes, it was first done, the bypass was done in 1954 by Kremer, the gastric bypass by Mason in 1967, the band in 1990, the sleeve gastrectomy. So Michel Gagne was my mentor. I've been with him at Mount Sinai, and I have the privilege of learning the sleeve gastrectomy with him and doing it in India in 2003. That's when I started. And of course, the ileal transposition, it's a Brazilian surgeon called Dr. Aureo Di Paula. I've been trained with him since 2008, and he has been instrumental in promoting the ileal transposition. So coming back to the restrictive part, it's very simple, a gastric balloon which can be done in an outpatient procedure. You insert a silicone balloon in the stomach and it stays for 6 to 8 months. Patient loses extra weight because they have a restricted input of calories. It has to be removed, it's a reversible procedure. Small role to play. But most of the conventional bariatric surgeries are now done laparoscopically through keyhole technique, 2, 3, 4 tiny cuts depending on the procedure. Why surgery? It definitely improves health conditions. The weight loss is sustained. Most of the patients are easily able to maintain their weight. It reduces the life-threatening risk factors, improves daily activity, improves their self-esteem and the confidence of the patient. Most of the patients ask me, why can't we just eat less and lose weight? How is surgery going to help? At the end of the day, you're just going to staple the stomach, you're going to remove half the stomach. Why can't I eat just a small amount of food and lose weight? But when the patient is on diet, they still are hungry. The appetite is still there, hunger is still there. They don't have the satiety they need. But with surgery, what we are doing is, because of certain chemical changes, the patients don't feel hungry after the surgery. They don't have so much of hunger, and the satiety levels are much higher. Plus, they lose those extra calories. Their metabolism goes up because of the various mechanical and hormonal changes they have. So they actually end up burning more calories compared to when they were without surgery. So the most important chemical, the USP of the surgery is ghrelin. This is situated in the fundus of the stomach, discovered in 1999. It triggers hunger in human beings. So when we are hungry at 1 o'clock lunchtime, it is because the ghrelin hormones are kicking in. And once we do a sleeve gastrectomy or a gastric bypass, these levels are drastically reduced. That's why these patients don't feel hungry. Now, the metabolic syndrome of the body deterioration is arrested. When you do a procedure, patient is controlled with diabetes. So the diabetic complications further that does not damage the organs like retinopathy, nephropathy, peripheral neuropathy. Hypertension and hypercholesterolemia are controlled very well. What we are trying to achieve is mechanical restriction, and there is something called metabolic restriction. Mechanical restriction because we are creating a small stomach pouch which restricts the amount of food the patient takes at one go. Vis-a-vis bariatric, liposuction, also patients lose some amount of weight, but it's totally different. Liposuction is only skeletal and body contouring, skeletal fat reduction and body contouring. It has got nothing to do with visceral fat. So it has got no therapeutic advantage other than losing few inches in your body. Whereas with bariatrics, we can help you come into remission with diabetes, hypertension control, cardiac function improvement, sleep apnea. Most of these patients go off their CPAP machines within a few weeks after surgery. Usually people have a fear for surgery. They treat it as a last resort. They would try everything. They would try pretty slim, they would try lipolysis. Bariatric is always considered last because of the fear with it. But there's nothing really to fear. Bariatric is not a cosmetic procedure. It is purely for medical reasons. Over the years, bariatric has evolved. The mechanics, the staplers, the vision, the camera system, the improvement, the surgeon's learning curve, everything has taken a different platform, and we stand at a much, much safer platform now. So we can compare bariatric surgery to any other surgery. The mortality meta-analysis is about 0.28% with bariatric surgery, which is comparable to any other surgery. What really changes after we do the procedure? Short-term changes, the GLP-1 and the GIP-1, and the long-term changes are leptin, adiponectin, and resistance. These are gut hormones which change after surgery. So in the sleeve vasectomy, which is the most popular procedure, a greater part of the stomach, the greater curvature is mobilized. We almost resect 60 to 70% of the stomach, leaving behind about 100-120 ml of stomach pouch. This is all done laparoscopically. It gives you very good hunger control. This is our port placement. So we just have 3 tiny ports, one for stapling and 2 as a working port. This is the laparoscopic video. So the stomach, greater curvature being mobilized using ultrasonic energy sources. So without the use of such high-end energy sources, this surgery is difficult. It almost makes it bloodless for us. We are dissecting the fundus of the stomach. You can see the CO junction there, the spleen on the right. The idea is to get the complete fundus out because we need the ghrelin completely out from the body. When we started, it took us almost 3 hours to finish the surgery. Now we can clock it in about 30-35 minutes. With practice, everything goes very smoothly. So we are completely mobilizing the fundus of the stomach. This is the left thrust of the, just stopped. Okay, so these are the staplers we use. These are endo-GI staplers. They come in 3-4 different sizes. Stomach, depending on the thickness of the stomach, usually we start at about 4 centimeters from the pylorus. That is the thickest part of the stomach. We use a thicker cartridge, the green or the black. We progress to use either a gold or the blue by the end of the, you can see the gold cartridge being used. This is the endo-GI 60. And in the end, we are using the blue cartridge towards the fundus of the stomach because fundus of the stomach is the thinnest. That is the portion which you have to take care. There's a calibration tube. There's a 36 French calibration tube introduced intraorally. You can also oversew the staple line just in case we are not sure. There's a small bleeding point. There's a small malformation of the staple. We don't need to take any chances. We can do a leak test to make sure that the stomach is absolutely airtight and watertight. We deliver the specimen always in a bag. Initially, we used to leave drains. Now, over the years, we realize that drain is not really necessary unless there is a problem. The next and the most wonderful procedure which has stood the test of time is the row Y gastric bypass. It is considered as the gold standard in bariatrics. We create a small stomach pouch, about 50 to 60 ml, a micro pouch. Leave the remnant stomach behind, measure about 50 centimeters from the DJ flexure, disconnect the jejunum, bring up the loop, do a GJ, a gastrojejunostomy. So the food directly enters the alimentary limb, this creates the alimentary limb, and the other limb, which is the BP limb, the biliopancreatic limb, brings the bile and other juices. So the common channel left behind would be about 300 to 350 centimeters. So the patient absorbs less calories, patient absorbs less oil, and they lose. Long-term results of the gastric bypass are very promising. It's a very good anti-diabetic procedure. This is our port placement for the bypass. So 1 3 mm for liver retraction, 1 stapling port, 1 camera port and 1 working port. Another new kid on the block has been the mini gastric bypass or the omega loop bypass. It's similar to the sleeve. We create a longish pouch, leave a remnant stomach, and we measure about 150 to 250 centimeters of jejunum and do a GG, a gastrojejunostomy. So the patient can eat a decent amount of food, but because of the malabsorptive component, these patients lose calories and they lose a lot of weight. It's a better procedure than the gastric bypass for diabetes, but there is slight complaint of gastric reflux in some of these patients because of the bile constantly being present in the stomach. So this is the stuff. Can you see the video? I can see here. The video is saying it's not showing me. We create a small stomach pouch, which is about again 100 centimeter pouch, and horizontal division first with a blue cartridge, and then all vertical to like a J-shaped stapling formation. We are using just one endo-GI, which is a flex endo-GI. It can be flexed in either direction. You can appreciate that. So this is the stomach pouch we are creating. This is the remnant stomach we are going to leave behind. This is called the gold finger, so we are dissecting the angle of his over there to make sure that our stapler goes through. So this is the last bit of the dissection in creating the stomach pouch. We have measured 150 centimeters from the DJ. This is the jejunum. We have created an enterotomy. Now we are doing a GJ, gastrojejunostomy, laparoscopic anastomosis. So this is the stomach on the left, the jejunum on the right. We are using a 60 blue cartridge. This is your anastomosis. And then we close the enterotomy. This is all done using 4 ports. Patient goes home next day on a liquid diet. Hospital stay is just 1 day. Surgical time is about 45 minutes. This can also be done robotically. So the robo can be handed over the instrument. It's a wonderful machine, the robo, Da Vinci. Same thing you saw. Laparoscopically, I'll show it to you robotically. So these are the robotic arms. This one. So there are 3 arms I'm using here. This is again the energy source during the dissection. Usual stapling, and then the GJ. So the advantage of the robo is that it has got an endo wrist. You can twist 360 degrees. Suturing becomes almost as neat and as fast as you're doing in an open surgery. The wrist can be twisted anyhow. The vision is 3D. The surgeon is sitting very comfortably on a console, and even long duration surgery, surgeon is very comfortable. You see how comfortably we are suturing with the robo, and keep guiding you all the time what instrument you are using, because your console has all the controls over there what are being done by the robo. So we've been increasing our numbers in India year on year. There's at least 30% growth in bariatric cases done every year in the country. In 2014, it was about 10,000. In 2017, we've done 20,000 cases all over the country. Numbers are increasing. Now coming to the world results of bariatric surgery. So this is a paper from 4 teaching hospitals where they compared lifestyle intensive medical management vis-a-vis the Roux-en-Y gastric bypass. What they observed that after 12 months of follow-up, Gastric bypass patients had 49% success rate, vis-a-vis only 19% in the medical management group in controlling HbA1c, cholesterol and blood pressure level. India is the diabetic capital of the world. There are about 171 million diabetics in the world, expected to double. India already has 4 crores and we are expected to double about 8 crores by the year 2030, which is very, very alarming. We know that diabesity is a difficult disease to treat. It has a progressive chart. Most patients will deteriorate over a period of time. Most therapies generate success, but only a small number of patients. Not every patient can be successful with medical management. Surgery works for these patients, but we have to choose our patients and surgeries properly. I'll skip this one. There was a paper by Porras published in 1995, and he had predicted that probably surgery is the answer for uncontrolled diabetics in the future. In the course of our bariatric career, we realized that diabetic patients are benefiting, and there was a little tweak to the bariatric procedures, and we called it metabolic procedures. So now we've designed procedures which don't make the patient lose too much weight, but then the metabolic syndrome is completely taken care of. There was a landmark trial done by Phil Shower from Cleveland, the Stampede trial. The 3-year and 5-year results are out, where he compared bariatric surgery with intensive medical management. What he found was HbA levels of 6 or less was achieved in only 5% medical patients compared to almost 30 to 25% with the bariatric patients. Coming to the quality of life, what do the patients want? Patients don't want to check their blood sugar every day. They don't want to take multiple injections. So the patients want something simpler. Now, we've all read in our endocrine books that it is all about insulin. So insulin fat has a property of creating insulin resistance. It's because of the inflammation. So most of these tissues are under inflammation, and this is the reason insulin has a resistance factor. Some of these patients, when they lose weight, the insulin starts acting better. There are other factors which play a role, the GLP-1, I'll come to that. I'll skip this. So, cure of diabetes is not dependent on weight alone, but there are other factors which are playing. I'm going to elaborate some of them. Most of these patients with metabolic surgery, they start getting rid of their diabetes or coming under remission without even losing weight. This is the result with the conventional methods of gastric banding, the sleeve, the bypass and the BPD. Of course, the bypass and the IEL transposition are the best for treating diabetes. There are results which are being published. This meta-analysis is comparing the band, the MGB, the sleeve, the room-wide gastric bypass, the biliopancreatic division, and the IEL transposition, where IEL transposition has fared the best, even in low BMI patients, because low BMI patients are the ones which are more difficult to treat compared to the high BMI patients for uncontrolled diabetes. There are newer surgeries which are devised on this theory. The DJB, the IEL transposition has 2 varieties, the regular IEL transposition and the diverted IEL transposition. I'll show you a picture where you'll understand. I said the Brazilian surgeon invented this Aurio Di Paula. What he discovered is that if I can somehow get the ileum up close to the duodenum, these patients will secrete more GLP-1. He observed that by doing this, almost 87% of his patients discontinued insulin or oral hypoglycemic agents or both. This is the diagram where we do a BMI adjusted sleeve. If the patient has extra weight, we do a sleeve. If the patient is not so over, we just do a fundectomy just to get rid of the ghrelin. The last part of the pointer, can I get a different color pointer? This green is not green. Yeah, the red pointer. So the ileum, 170 centimeters of the ileum loop is disconnected, mobilized, and we transpose it right after the duodenum. If we do it 50 centimeters after the duodenum, it is the ileal transposition. If we do it right at the duodenum, it is called the diverted ileal transposition. The diverted is the stronger version of the ileal transposition. For certain patients, we have a grading system to assess what is the severity of this disease. So the ileal segment has some certain hormone secreting cells, the L cells, which secrete GLP-1 when they come in contact with undigested food. By the time the food travels from the jejunum to the ileum, the food has changed its constitution. And this GLP-1 goes to the pancreas via the blood and helps it secrete more insulin. This is the mechanism of success of this surgery. His result, 87% patients had perfect glycemic control. Rest of the 13% had significant improvement. No insulin post-operatively. All patients, the cholesterol levels came to normal. Hypertension disappeared. How do we choose these patients? So we have to do certain blood tests wherein we are looking at the C-peptide levels. If the C-peptide, which is the beta cell activity of the pancreas, are intact, then we know that these patients will do well. Over a period of time, if the beta cells have died out because of diabetes, then these patients are not going to do so well. This is done through a laparoscopic technique, 5 small pores. I have a video. It's a little complicated, but I'll just run through it just to give you a brief idea how it is. So we have basically jejunum, jejunum ileum, which is about 7 to 8 meters long. We want to mobilize 170 centimeters of the ileal segment. We measure it from the IC junction, 30 centimeters, mobilize 100 centimeters of ileum, disconnect it, and we disconnect the jejunum at 50 centimeters. So there are 3 transactions, 6 loose ends of the intestine line. So we need to number and label them properly. And then we need to anastomose them. So we have a way of labeling them. Either we put a single suture thread marker or a double suture thread marker or a cautery marker. So we have 3 different markers. This is how we do it. So we mobilize 170 centimeters and then we do a laparoscopic anastomosis using the white GI cartridge, side-to-side anastomosis. You're seeing these 2 loops of, this is the segment, one is the segment, one is the jejunum being anastomosed together. And then we close the intraotomy. Marking is very important in this surgery, otherwise you can create a mess because there are 6 loose ends and they can really be confusing. It takes almost 3 hours to finish this, but then the patient is off insulin within a few weeks of the procedure. So as I was mentioning that obese patients, because of peripheral insulin resistance, are easier to treat because once they lose weight, they're going to do well. But the non-obese category, the disease is mainly gluconeocentric disease. So we need something stronger. We need a strong GLP-1 effect to take care of this. There are different procedures. There are so many different procedures. How do you choose which procedure is good for the patient? Just because you're trained in 1 or 2 particular procedures and you offer that to the patient is not a good idea. You have to be trained and offer the right procedure for the right patient. There are multiple factors which help you choose parameters, efficacy, safety, BMI, age, HbA1c level, duration of disease. So we have a scoring system which we follow. So there are 9 parameters, age of the patient, and accordingly we give score of 1 or 2. 2 is more severe, 1 is less severe. So more than 60 and less than 30 years are the more severe patients. BMI of less than 27, low BMI are more difficult to treat for diabetes. Duration of diabetes more than 10 years, more difficult. Microvascular and macrovascular changes present, difficulty level is high. On insulin, if C-peptide levels are less than 4, then chances of remission of diabetes are less. And of course, HbA level of 1C, HbA level of 8 plus is uncontrolled diabetes. These are the ones who will really benefit from the surgery. So, grading 1, 2 and 3 depending on the score. If it's grade 3, then we do the diverted ileal transposition. If it's grade 1 or 2, then we do the regular ileal transposition. What happens after the surgery from the hormone point of view? GLP-1 and GIP exhibit a rise. Insulin and amylin show a significant rise in 30 minutes after ingestion of food. PYY rises. Glucagon activity is decreased. Ghrelin shows significant decrease because of the fundus is gone. Both leptin and resistant blood levels are decreased. And adiponectin showed a slight increase. This is how the hormones work in the favor of surgery. Okay. So there's another trial conducted, paper published,
from UK where almost 3,000 patients with diabetes were subjected to either medical treatment or surgery. So 569 patients underwent surgery and 1,881 were in the control group. There was 94.5% remission of diabetes compared to only 5% in the control group. Again, the duration of diabetes, I need to harp on this. Patients who were subjected to surgery within 5 years of diabetes showed 90% remission compared to patients who were subjected to more than 5 years of diabetic disease. They had only 57% remission. Of course, BMI, lower BMI were more difficult to treat. There are certain drugs available in the market like Januvia and Biota, which are GLP-1, they mimic GLP-1, but they have to be taken continuously for them to show effects. But even with these drugs, they are nowhere compared to the surgery because with surgery, the effects are almost 3x or 4x higher compared to anything else, exercise, drugs, GLP-1, anything you do, but surgery results are 3x or 4x after surgery, after the GLP-1 effects after surgery. Different procedures showing different GLP-1 levels. So you see the ideal transposition showing 4 and the bypass showing levels 3 plus increase after GLP-1 after surgery. Another successful procedure which has stood the test of time is the deodal switch. Even after 20 years of surgery, 91% of the patients have maintained their remission levels and only 6% recurrence of diabetes after 20 years. The Lancet, the Diabetic and Endocrinology journal, had a question that why bariatric surgery should be a last resort. Let us offer these procedures to patients early in life so that they benefit out of it. Surgery achieves better long-term results compared to any other rare medical therapy. In these patients, microatherosclerosis starts much before they start manifesting hyperglycemia. In order to get the maximum benefit out of it, we need to subject these patients to surgery early if possible, and we can now offer it to non-obese patients in a selected group of patients with uncontrolled diabetes. We as teachers and doctors can preach our patients to eat small healthy meals, exercise regularly, try and reduce stress in whatever way it takes. If needed, take our medications regularly. Remember, India has 4 crore diabetics and are growing to 8 crores. You would not recognize some of the most beautiful people if they put on weight. Can you guess who she is? Is there anything sleeping? She's Elizabeth Hurley if she puts on weight. Want to see her again? Can you guess who she is? You don't watch movies or what? Bollywood, Hollywood? Yes, if she puts on weight, this is what she will become like. Any idea who she is? She's Julia Roberts. If she puts on weight, this is what she looks like. Okay, one more. She's Sandra Bullock. If she puts on weight, this is what she looks like. Last one. Okay, she's Kathleen Zeta-Jones. If she puts on weight, this is what she looks like. So this could happen to anyone. So it's time for all of us to eat right, exercise more, live a healthy and fruitful life. In our personal experience, we have done a sizable number of cases since 2002 with very good results. Just one mortality because of medical conditions. Most of the complications are very minimal, 1%. Excess weight loss was in the range of 56 to 92%. We don't promise that we create a beauty queen out of every patient which comes to us, but yes, Most of these patients will have a weight loss of 50 to 80%, improvement in comorbidities, improvement in quality of life, and significantly prolong their life with better quality of life. Some of the patient results, most of these patients are off insulin and tablets. They lose a hell of a lot of weight. Some of them have lost 100 kilos of weight. This is one of my most difficult patients. He was diabetic for 30 years, on insulin for 18 years, 230 units of insulin every day, HbA1c of 13. We did the diverted ideal. After 6 months after surgery, he's lost almost 50 kilos, 40 kilos. He's off insulin, only on one tablet of Amaryl, doing wonderful. This is one of the heaviest we have done, 245 kilos. He's lost 125 kilos. One of the youngest patients, he was 11 years old, weighing 148 kilos. He's lost 50 kilos and he's very active now. This guy lost 100 kilos. He's 195. His waist was 100 inches. I'm standing next to him, you can see him. Another super heavy diabetic, 270 units of insulin, completely off. Young guy, 24 years old, 198 kilos, he's lost 110 kilos. So most of these guys do wonderfully well after surgery, provided they follow the advice. So surgery is the most effective for uncontrolled diabetics and morbidly obese. There are different options. Choose the right procedure for the right patient. I'll be happy to answer any of the patient queries if they contact me during office hours. I'm ready to take some questions if you have. Yes? We are racing against time. We need to catch up soon. No, I can't see them.
New gastrectomy or gastric bypass, does it hamper digestion of proteins or absorption of B12 because of Cassell's factor?
So with sleeve gastrectomy, it's only a mechanical restriction. There is no malabsorption whatsoever. But with procedures like the MGB or the row-wide gastric bypass, they need protein supplements. We suggest 70-80 grams of proteins every day.
B12?
B12, yes. All of them need B12 supplementation. Thank you. That's it? Yes? Can you take a mic? I can't hear you.
After the surgery, the patient develops, what would it develop some kind of cancer or tuberculosis, something that his appetite naturally falls very drastically. So in those conditions, what would it
So most of these patients will be able to take 7-8 meals a day. See, what happens is instead of 2 meals, they go on a 7-meal pattern. They almost end up eating the same amount but in divided doses. See, most of the patients can undergo pregnancy. Young patients who undergo sleeve gastrectomy, they lose so much weight, the infertility is gone, and they are pregnant. And they are able to take sufficient diet, not an issue. Yes? Just keep it close, I can't hear you.
This procedure is said to increase the quality of life of these patients.
Yeah.
Then what about the other complications caused by it? Surely the patient would be on lot of restricted diets and will need lifelong supplementation of all the nutrients, lot of nutrients, and also they are prone to develop malnutrition. How will that affect the patient?
Most of these patients will need some sort of vitamin supplementation. And vitamins, I said, proteins, I said everybody needs, whether you've undergone bariatric or not. We all need 70-80 grams of protein a day, which we don't take. So protein is a mandatory part of your diet. And most of these patients are so happy after losing weight because they fit into their clothes, their life is better, they are socially more acceptable, they get better jobs, they are more energetic, they're rid of their CPAP machines, their diabetes, their cholesterol. So overall, it's a feel-good factor. we have a quality of life index, SQL. So they fare much better in quality of life after surgery.
Thank you.
Thank you.